This is Jeff from FX Physical Therapy. I'm here today to talk to Dr. Sean Meredith from the University of Maryland Medical System. Dr. Meredith is an assistant prof at University of Maryland School of Medicine. He's an expert in the management of shoulder, hip, and knee pain and specializes in arthroscopic techniques, including ligament repair and reconstruction, cartilage transplantation, tendon repair, osteotomies, and joint replacement. Dr. Meredith has a particular interest in hip arthroscopy for the management of femoral acetabular impingement, or FAI, which is going to be an area of emphasis in our discussion today. So thanks, Dr. Meredith, for taking some time out of your day to talk to us about hip pain.
Of course. Thanks for having me.
So one of the questions that we get asked a lot by our patients is what type of doctor they should see when they're experiencing pain. What are the types of injuries that you usually see in your office as a sports and ortho physician?
Sure. So as you mentioned, I take care of shoulders, knees, and hips. Hips is certainly my sort of niche and one of my bigger points of emphasis, and I see more patients for hip issues. But I would say that I see a range of athletes from our high-level college athletes to the high school athletes and even younger, and then the weekend warriors and people that are just staying active and playing sports, either recreationally or competitively. And so, we see a range of things in my clinic, certainly acute injuries from sports and many, many overuse injuries, especially with people staying active more and more.
Awesome. So when somebody comes in, and the types of injuries that you see, how many of those are you seeing that typically are leading to a surgical procedure or more that type of intervention versus ones that can be dealt with more conservatively?
Sure. I would say overall, more often, most things can be treated conservatively. The minority of patients end up needing surgery. Certainly, we see a high volume of patients and many of the common sort of muscle sprains or muscle strains and joint sprains and those things, many are treated without surgery. And as we work with you guys and all the physical therapists, many of these injuries can be treated without surgery. So I would say the minority end up having to have surgery, and we try to treat most things conservatively at first. Of course, there's some things that are more amenable to treatment conservatively, and there's things that we find don't do as well conservatively, and then we recommend surgery for those.
Okay, that's perfect. That leads into the next question a little bit. Speaking about hip arthroscopy in particular, and with femoral acetabular impingement, with FAI, what are the types of patients that typically respond well versus maybe some things that we can look for a patient that who's maybe more of a surgical candidate?
Sure. Okay. So I guess I would start by saying one of the potentially interesting things and somewhat challenging about hip issues in general is there's a lot of overlap. So pain around the hip takes a significant amount of time and work to figure out where it's coming from. There's overlap with issues with the back and the lumbar spine, the lower spine. And there's certainly lots of overlap with radicular symptoms, radiating pain from the back, from nerve issues. And then we like to think of the hip in multiple layers. So there's sort of all of the muscles and tendons around the hip, and then down into the joint where you have things like FAI or hip impingement and labral tears that can go along with that. So in general, I would say one of the things that's important for me is sort of figuring out what truly is the cause of the pain. And whether we think it's truly from the hip, or is it from the back, or is it from the knee, or something else. There's even overlap with pelvic problems, whether those be intra-abdominal organs and all of other medical issues, as well as what we see more often is with athletic people is core muscle injury, the sports hernia. So for figuring out who's going to be treated with surgery versus conservative is somewhat tricky. A lot of these things will give them a chance without surgery regardless, in some sense of it. So femoral acetabular impingement or hip impingement, a lot of times, the large majority of the time, it's treated non-operatively and conservatively first. I see lots of patients who have been to multiple physicians and sort of trying to figure this out, and finally get to me or, you know, someone else like me who specializes truly in taking care of young people with hip issues. And a lot are still, even at that point, are still treated conservatively. So there's not necessarily an easy way to figure out who's not going to respond to conservative measures first. I always like to have any of the young patients with hip pain working collaboratively between me and you and me and one of the physical therapists. So I think it sort of takes both perspectives to figure this out. Now, once they get to me, and if they've already done some conservative treatment, there's things that I look for specifically on imaging per se or on the exam that give me a clue that this patient may not be responding for some reason to the non-operative treatment. So one example would be, I get x-rays on everyone that has hip pain that I think might have some true hip issue, of which many end up being FAI or hip impingement. And we know from the literature and from the orthopedic studies out there that people that have larger CAM lesions, which is one type of hip impingement or FAI, if they're larger, there's been multiple studies that have sort of pointed to the chance that those might not do as well without surgery and have a higher chance of failing non-operative treatment and end up having surgery for their FAI. So that might be one sort of example of when I see someone in the office who's already been doing physical therapy, if they're not doing well with it, it's one thing that we look for. I measure these angles and all sorts of things to quantify things on x-ray, is one sort of example. But it's certainly a tricky thing to figure out who's going to respond better to conservative treatment or surgical treatment. Certainly trying not surgery, I think, is always a nice way to start.
That's great. Thank you. With, these days with the way things are, gyms having been closed, seeing a lot more people out on the streets, running in particular, have you noticed an increase in hip pain in maybe a running population or just people in general? And what's the type of presentation that you're seeing the most right now?
Yeah, so running specifically would be kind of on the medium to higher risk category. If you were to ask a whole bunch of people like me, hip surgeons, we would classify running as sort of medium to higher risk for having issues with the hip. So we certainly see a lot. As you mentioned, people are trying to find ways to stay active, and running is definitely one, with gyms being closed. And there's lots of different diagnoses we end up coming up to in runners. I would lead with saying the first thing that I am always making sure that we don't miss is a stress fracture in the hip from running. So it's especially important now where people are running who haven't been running or people that are increasing their mileage, we're looking for the sort of classic descriptions of people that have weight-bearing pain, and as they run, they get more and more of this deep groin pain, and is specifically associated with weight-bearing, and then specifically associated with people that are increasing or doing it and they haven't been doing it before. So that's something that we can't miss, and important for us to make sure that's not the situation. A lot of times we can figure it out just based on talking to a patient and listening to their story. When we can't tell and we're worried, we use MRIs to make sure people don't have stress fracture. But that being said, muscle strains and are common. In runners, we certainly get issues with the knees that sort of will give us referred pain. With the hip, IT band issues, we see a lot. And then specific to the hip, lots of snapping hips. So whether that's IT band snapping on the outside of the hip or iliopsoas or hip flexor snapping in the front of the hip, we certainly see that a lot. And FAI is common. Probably one of the reasons that I focus on it and many people focus on it is we've seen in the orthopedic literature that it's the most common thing probably in a young person with hip pain that doesn't have any other underlying issues. FAI is probably the most common diagnosis when you end up getting to an orthopedic surgeon that specializes in the hip. So FAI is definitely common. FAI, we should really just be including labral tears in this too, because the large majority of labral tears are caused by FAI or hip impingement.
Okay, so patient comes in, fairly, let's say, recent onset of hip pain. What are your sort of go-to strategies to start to maybe reduce some of that pain in a conservative manner?
Yeah, most often if the physical exam, like I said, if I've ruled out a stress fracture and we think it might be any one of these other causes, starting with simple things is always the best and easiest thing to do. So at times we need to modify what people are doing. Using anti-inflammatory medications is something we do as long as their medical history allows them to do that and they don't have any reason why they can't take anti-inflammatories. So just even simple things like over-the-counter ibuprofen or Motrin or Aleve or naproxen are the most common ones. And starting with simple things there and utilizing you guys, the physical therapists, for your expertise is extremely helpful. It sort of helps in that early on period to help figure out where their issues are, where their deficits are. And it's important now as people are trying to get more and more active and doing things they weren't normally doing, that especially with the hip, your core needs to be strong and your back needs to be strong. And those things are all important. So yeah, to answer your question, we always start with those sort of, simple things first and slowly escalate things. But sort of coming up with the diagnosis and figuring out why the person is having pain is the most important thing. And that's why us working with you guys, having a hip specialist and a physical therapist working together is just the best way to do it because you have it from both perspectives.
Gotcha. That's perfect. So now patients come in, they've had some hip pain that's maybe a little bit more persistent, had the x-rays, diagnosis of FAI based on that imaging. Is there anything that you recommend that person should avoid? Are there any activities in the short term and long term that they should do less of or maybe take some precautions when doing?
Sure, good question. So in general, one of the things that I like about my job is trying to keep people active and doing what they want to do. So I sort of somewhat have this bias that I try not to tell people, oh, you can't run ever again, or you can't play basketball, or that sort of thing. Now, as you're hinting at here, we need to modify things at times where people are doing it. So with FAI, we know that people have more issues with things that require high hip flexion, so bringing your hip, flexing your hip all the way forward and up, and things that put rotational torque on the hip, so pivoting on the hip. So those two things are what are the toughest for FAI. So when the hip goes up into high flexion, that's when you get the impingement. And so as I like to tell patients, the FAI, it's a mismatch between the ball and the socket. Either the socket sticks out too much or the ball's got a bump and it hits the socket. For one reason or another, the socket and the ball don't match perfectly and you get impingement, it pinches. and the two bones bang together, and then you can injure the labrum because the labrum's right in between the two of them. And so avoiding those high hip flexion things that cause the impingement is something to do early on. When people have gradually, they're people not doing as well and have had hip impingement for some time, the torque and the rotating on the hip, it's thought that that puts more stress on the labrum. And if you already have an injury to the labrum or a labral tear, that potentially is just going to be a harder activity for the person to do. So in the short term, we sort of try to jump on it really quick and modify those things and aggressively avoid those. And then once they're working with the physical therapist, with you guys, and they start learning how to control their pelvic tilt and keep themselves out of this impingement point, then we can sort of gradually get them back to doing those things. If, for example, some high flexion hip activity was something that was important to them, then we gradually get them back into it.
Okay, that's good. If a person, FAI and diagnosed labral tear, conservative management doesn't seem to be working. Surgery seems indicated. Afterwards, is there, let's say this person wants to get back to some level of, fairly high level activity. Is there any limitations that that person's going to have in the long run, or anything that they're not going to be able to do if they choose to go ahead with a surgical procedure?
Yeah, so when we look at returning to sports or returning to any activity, there's plenty of research that's been done in different levels of athletes and getting back to activity. So if we use running as the example, so this has been studied and it's been reported that returning to running after having surgery for FAI, having hip arthroscopy and having a labral repair and having the bony abnormality corrected, about 90% of people can return to running as they would like to. So it's not 100%. In all of orthopedic surgeries throughout the entire body, there's never 100% of returning to sport. Now, there's multiple factors that play into that. Some people choose not to, so you would never get 100% when we study these things and follow people long term. But after hip arthroscopy, the return to sports rates are high compared to many surgeries. And we compare a lot of things to ACL surgery because that's a common thing that's been studied in return to sport. And most of the return to sports for hip is probably slightly higher than ACL surgery. So in general, it's pretty good. And we don't say that there's anything necessarily that they can't get back to. The hardest sports to get back to after hip arthroscopy is probably basketball from what's been studied in the literature. And that's probably closer to 80% returning to playing basketball like they would like to. So there's lots of numbers like that that have been thrown out there and studied and reported in studies. But the return to sports for hips are pretty good. And so when people come to me and they end up not doing it, non-operative treatment doesn't work, we end up going down the road of surgery. I tell them this. I tell them that most things we try to get you back to. People certainly make decisions whether how important certain activities are to them and decide which ones are really important to them. And then we sort of focus and try to get their rehab focused so that they're in the best position to get back to the sport or activity that they want.
Yeah, great. When somebody comes to see you for hip pain, what are the circumstances or what's the presentation that might lead you to recommend physical therapy for that person?
Sure. So I would say with FAI, the sort of classic run-of-the-mill FAI that I would see would be someone young in their 20s would probably be most common. We don't see much FAI younger than, I would say, around 16. We think the bony abnormality in FAI develops when their growth plates are closing, so when they're finishing their growth spurt. It happens then, and then most people think that it takes a little bit of time for this impingement to be bothering them before they actually come and see one of me or you. And so I'm usually seeing young people, and they're describing pain in the front of their hip, and they're describing pain with activities often, with sitting for periods of time, because that sort of brings their hip up, and they have difficulty with that. And if patients haven't had much treatment yet, often, patient will have tried some ibuprofen at home, taken a break from things, and it's still bothering them. Most of the people that have sort of that classic FAI description, I do send to physical therapy. I think it's it's a good way to start, because a lot of people, just with the dynamics and everything that you're able to do with the patients, you're able to keep them out of this impingement. It's not really an issue, especially if you jump on it early. Now, there's a spectrum of patients I see. So I see some patients like that haven't really had much treatment. I see many more patients that had seen another orthopedic doctor who's doesn't necessarily specialize in hip, and they've tried some simple things, and they've tried some physical therapy. I will send many patients back to physical therapy because it hasn't always been focused on their hip. So a patient may come in and said, yeah, I've done some physical therapy, and they gave me these exercises to do, and I try to ask patients what actually they did in their physical therapy to figure out if it was focused on sort of the right things or not. Of course, it's hard to cover everything. I'm sure you know this as a therapist. You can't have them work on their back, their hip, their knee, and try to focus on all different things, and then different things within the hip. There's so many things you could potentially do that I often find myself trying to figure out what they've actually done in physical therapy. And I find many times that I'm sending them back for another round of physical therapy because we want to focus it in better. On maybe it's been, focused on the back, and we're going to focus it more on the hip, or it's been more on the knee, and we're going to focus on more on the hip, or for the hip, it's been focused on not exactly where we feel like we could best tailor it to. So many patients are going back to physical therapy after having been, and I'll tell you, many patients come back to me and they'll say that completely was the right answer. I just needed a different sort of regimen in physical therapy. Yeah, I think that answers your question.
Yeah, absolutely. No, it totally did. How much physical therapy would somebody attempt before you would consider it ineffective and maybe escalate it to another intervention?
Yeah, good question. That's sometimes very hard. I would say that I think a lot of hip orthopedic surgeons feel like some patients can tell early on if it's working and some can't. So, for example, I'll have some patients who will come to me in 2 weeks. They sort of have a sense that things are improving, things are going right. They sort of know, and we don't know why that is. It might just be that the patient can sense things and they can start to feel the dynamics of their hip changing. So some people early on sort of get a sense that it's going right. And when they tell me that, I tell them to sort of maximize it. Now, typically, I recommend people do 6 or 8 weeks of physical therapy when we start. But I tell them to try to figure out early on if they feel like things are going in the right direction or not. So if they feel like it is working, even in that first 2, or if they feel like it's working in the first 4 weeks, I tell them to maximize 6, 8 weeks, maybe even longer if they sort of get where they want, but they're not all the way back to, say, they were, sort of playing high level recreational sports. They may go longer than that for sure, to sort of gradually progression into sort of a return to sport type way. Now, some patients will be in the middle of that initial 6 weeks and get a sense that things are really getting worse. or just not helping at all. And so my first thing is to sort of figure out if there's something that just is bothering them in therapy. Is there just one exercise? Are they trying to do hip flexor strengthening? It's just irritating their hip flexor because they have a big cam lesion. And so that big bump is right on the hip flexor. They're trying to do strengthening for it. And I say, you just cut that out and then you may be able to fix it. Now, some people aren't doing anything like that and they're doing, good core and glute strengthening and pelvic tilt and all these things, and they still feel like it's not getting better. If I can't figure out something going wrong in therapy, then there are times when people don't make it through the first, 6 weeks that I suggest they do. And we may suggest an injection, for example, or we may say, hey, you've got maybe some other risk factors for not doing well without surgery, and maybe we will decide to go to surgery sooner rather than later. In general, I try not to. We try to sort of maximize the non-operative treatment before we jump into the surgery, but there can be times where everything is pointing to non-operative treatment not working well, and then we switch to go down the surgery route, but not often.
What can you elaborate on those risk factors that you might look for that suggest the person may be a good surgical candidate?
Yeah, so things for me are things there's some things on physical exam. So, everyone, of course, we do the standard sort of flexion, adduction, internal rotation tests and put their hip in that impingement position and see, if that exactly reproduces their pain. So when people are sort of in lower hip flexion or less internal rotation, they're getting more pain. I feel like is, maybe a worse thing. There's not any evidence on that per se, but that's sort of a bad sign to me. When I start my physical exam, I do a log roll on every hip. And if people are having pain just with log roll, then I know their capsule's irritated and they're having a lot of pain. And maybe that doesn't lead us to surgery, but I know we need to sort of take it easy on the hip and sort of let things relax before we do too much. Now, there is cases where people never overcome that, and then we go down surgery earlier. On imaging, I mentioned earlier, so large cam lesions. So we measure this on special X-ray series that I get in the office, and we measure sort of how big the bump is of the cam lesion, how much extra bone there is on the ball side, and higher degrees, more bigger alpha angles, one of the measurements we do, for example. And there's been studies that show if it's much bigger, that's going to be a risk factor. I look at the MRIs closely. I look at the cartilage closely on the MRI. One of the problems with hip impingement and FAI is as it progresses over time, we know it's a risk factor for getting arthritis when people get older. Now, just because you have FAI does not mean you're going to automatically get hip arthritis, because most people aren't going to. But it is one risk factor potentially for getting arthritis. So when I see that there's a young person with a large cam lesion and someone that's maybe already starting to get some cartilage injury, I worry. The theories that are out there now are that as the FAI gets worse, a labral tear happens first, and then the progression, the damage starts going into the cartilage, into more of toward the middle of the hip. And it sort of progresses from the edge where the labrum is into the cartilage. And when people are starting to get cartilage damage early, articular cartilage damage, the sort of lining of the joint, when they're getting that damage early, that's a potential worrisome sign. And so they may go down the road of surgery earlier. Of course, you have to get to the point of having an MRI to get to that. Certainly, you can get the X-ray measurements and get that earlier, and the physical getting to the MRI point is where you need to go to get the cartilage injury. Now, most people, if they have not had an MRI and they're seeing me, and I think it's FAI, they don't have to have an MRI. I can see FAI, the bony shape on the X-ray, if their physical exam and their story lines up with it. We say that there's often a high chance they're going to have a labral tear, and we don't have to have the MRI to show it, because no matter what, it's not going to change what we do. We're still going to potentially treat it conservatively. And so I don't worry about them having cartilage damage from the beginning, because if they do physical therapy for 6 months, or for 6 weeks, sorry, it's extremely likely to change what the cartilage looks like. Cartilage damage takes months to years really to progress. So it's most likely that it takes years to progress. So the immediacy of an MRI is not always necessary. Now, certainly we get them plenty of times to sort of get a baseline and figure out where the labral tear and how big it is. But the cartilage is one thing certainly that I look at.
Okay, that's perfect. For people who are your typical athletes, weekend warriors, they just want to be able to continue to run or cycle, work out, all those sorts of things. Any advice on just general kind of hip maintenance? Is there anything that you recommend for people to maybe avoid the development of pain in the first place?
Yeah, certainly. It's good. I think that this is important. So I would say you need to have good core strength. So we know that core strength and having issues with your hip are directly related. So keeping your core muscles, your abs strong, your low back strong, that's important. So I think people in general, when you're trying to stay active and you're trying to be out there and be able to play sports on the weekend or do whatever you want to do on the weekend, keeping your core strong is important. And many people can do that on their own, can figure out the right exercises to do. And some people will work with a physical therapist to sort of get a really good program on it, especially if they're more serious about the weekend activities that they do, for example. But I'll say core strength is good. Keeping flexibility is good. So there's been plenty of look into yoga now that it's become so popular, and studies on yoga, and there's benefits to it. We know that flexibility is important. So hamstring flexibility is probably specifically important to the hip. Tight hamstrings can play a role in sort of throwing off the hip, and keeping your glute strong. So some sort of glute strengthening exercises would be key. A lot of people that I see that end up getting issues and getting into this repetitive pain with FAI or hip impingement is people that have really weak glutes and don't activate their glutes well, are not using the strength of those big muscles routinely. So keeping your glutes strong, keeping your core strong, staying flexible, I would say those are all important things.
Okay, that's great. So just in wrapping up, if people are experiencing hip issues, they maybe they've tried conservative management, or they feel like they need an expert opinion, where can people find you?
Yeah, so I'm in multiple of our offices. So the University of Maryland Orthopaedics, we've got multiple offices all around. I personally see patients at Rehab and Ortho, which is on the west edge of the Baltimore City, Baltimore County line, where 70 and 695 meet. I see patients in Camden Yards. I see patients north of the city in Timonium. And soon we'll have our big complex down in College Park for patients to see us at. But certainly they can find University of Maryland Orthopaedics online and get an appointment to see me or one of my partners. Yeah, I think anyone that has issues or concerns with their hip should see a sports medicine, orthopedic surgeon, and someone that specializes in hip is certainly the best, because hip is somewhat unique for the people that are taking care of it, and in your world too, where there's people that are focused on taking care of hips. So I think it's helpful for patients to know they should see us. They shouldn't be worried about coming to see me. They're not automatically going to need surgery. They should hopefully be open to seeing me, to seeing you, to seeing physical therapy, because many of these issues can be solved with simple things.
Awesome. Thank you so much. Thanks again for taking some time out of your day. It was really insightful. I appreciate all the thoughts around both surgical and conservative management. And again, thanks for taking the time.
Yeah, of course. Thanks for having me.